Hi, my name is Kimberly Perez. I'm a medical oncologist from Dana-Farber Cancer Institute, and I specialize in neuroendocrine tumor treatment and clinical trial development. And I've the privilege today of discussing with all of you NETs and NECs 101. These are my disclosures. So I'm hopeful today to go through a few questions that I think commonly come up, not only for the patient that is newly diagnosed, but even the patient that has been carrying the diagnosis for some time as treatment decisions come up and new therapies become options. I think there are important information about your disease that every patient should try to understand in order to make this journey more understandable. So, first, we'll start with a very big distinction, which is, do I have neuroendocrine tumor or do I have neuroendocrine cancer? How and why do they differ? The next is, how do I read my pathology report? What's important? Anatomic site of origin, histology. What is this Ki-67 everyone's talking about? Molecular characteristics that are important. And what about functional disease? Do I have that? What's carcinoid syndrome? Do I have that? Is that relevant? I keep seeing CAT scans, MRIs, PET scans, something called dotatate, gallium. What am I supposed to get? And how does my team use that to confirm my diagnosis? Additionally, what are the treatment options? I'm hearing all about new drugs that have been FDA approved, and are those options for me based on my diagnosis? Another common question is, do I need cancer blood work? How come this wasn't identified with blood work prior to my diagnosis? And what blood work should I be getting going forward now that I know that I carry the diagnosis of neuroendocrine? And finally, just briefly, I'll touch on, did I inherit the risk of developing my cancer? So I think many people ask, what is neuroendocrine tumor? I've never heard of that before. And I think what's important to know is that our bodies are composed of many different types of cells. And so the common types of cancer, like colon cancer, breast cancer, lung cancer, those cancers develop from the most common type of cell that comprises that organ. What we don't have is a neuroendocrine organ, but what we do have are neuroendocrine cells that reside in many different parts of the body. And the reason that they do is that they're amazing cells that actually have characteristics of neurons or nerves and also hormone producing cells, endocrine cells. And that's where the name neuroendocrine is derived from. So really the reason why they're in not just one organ, but multiple organs throughout the body is because the brain needs a way to send information or signals to the other parts of the body in order to make things happen. And so on the right, you can see this cartoon graphic, which is from the NetRF site, which has this process. And so you have the brain taking in some environmental change or stimulus, and it needs to tell the body how to react to it. And that's what the healthy neuroendocrine system does. So the signals get passed through nerves, then the electrical signals get to the neuroendocrine cells, and the neuroendocrine cells release hormones or protein signals to the various parts of the body, whether it be muscles, blood vessels, the pancreas cells that instruct the body to make insulin or release proteins to help you digest your food. So there's so many organs that are directly affected by the neuroendocrine system, and that's why it doesn't have one organ that it is unique to, and it's actually found all over the body. The neuroendocrine system has been integrated throughout the body since the time of embryologic development. And we now, as clinical scientists, use that embryologic origin as a means to label the different areas of the body that the neuroendocrine system resides in. So you have the body broken up into the foregut, midgut, and hindgut. And as you're diving into the world of neuroendocrine, you're going to see many different references to these different parts of the body. So this is where it stems from, is that although you may be diagnosed with a lung neuroendocrine tumor or a neuroendocrine tumor of the pancreas, in a clinical trial, we may group that all together as a foregut neuroendocrine tumor. And it's not that those organs are similar, it's just that we know from embryologic origin they develop from a very similar cell. And then you have midgut and hindgut with the same kind of thought process. So when we break it down, there's actually some method to this madness in that there is the distribution may be everywhere, but the tumors that develop from these areas do vary. So you have the lung or the bronchus, those are the airways, where you can have upwards of 20 to 25% of neuroendocrine tumors develop. The pancreas, 17 to 20%. The small intestine is probably the most common organ in which we develop neuroendocrine tumors at 55%. And then the other areas of the body where we develop neuroendocrine tumors are much less common. So we're looking at less than 5% of all neuroendocrine tumors developing in the rectum or the colon, the thyroid, the adrenal glands, the ovary, or the cervix. And so I'm going to jump a little bit because I think this is one of the biggest questions that is asked of me when I meet patients for their first consultation is, do I have cancer? And I think what we as oncologists take for granted is there's many different terms that are used to describe cancer. And during someone's journey through their diagnosis, it becomes very confusing. And so I share here on the left side of the slide just different terms that you may have heard applied to findings that led to your cancer diagnosis, whether tumor is the most common, mass, lesion, growth, lump, malignancy. Those are just a handful of the terms that you may have heard, and they all mean the same thing, which is there's an abnormality that we're seeing either on your exam or on your imaging that it's not something that's supposed to be there. And it's bigger or getting bigger than it should be. And so that's how we kind of doctor to doctor or clinician to clinician can speak the same language by using these terms. But I appreciate that it can be very confusing for a patient because you can have any one of these terms used and it's not a cancer. What really makes it a cancer is not only that it's growing uncontrollably, our bodies don't have control over the individual cells constantly growing or replicating, but what differs from just a mass or a lump or a tumor that is not cancerous is that these cells within the mass, tumor, lesion, whatever it is, have the ability to spread. So they have the ability to leave that initial mass or tumor and go somewhere else in the body. And so that is how we distinguish something that is a mass and something that is a cancer. And although we use the term carcinoid tumor, it is a cancer because we know that these carcinoid tumors or neuroendocrine tumors have the ability to grow uncontrollably, and also they have the ability to spread to other parts of the body. And so that is the reason why carcinoid tumor was initially used and why there's a lot of confusion around whether or not this is a cancer or not, depending on the specialist that you're seeing, is really because of the slow rate of growth. And initially, when it was first identified, the tumors that fell into this classification were so slow growing that the scientists at the time thought that they weren't cancer. But what they soon realized was that because they were able to spread, that they actually met the definition for cancer. This slide is intended to describe the title of this talk, which is neuroendocrine tumor versus neuroendocrine cancer. What's the difference? So you'll see on this slide, it's a bit of alphabet soup, but you have carcinoid tumor, which is what many of you will have heard as a description of your disease. And many of you will have heard well-differentiated neuroendocrine tumor. Those are the same term. And it's really just clinician dependent in regards to whether one is used over the other. Poorly differentiated endocrine carcinoma is a different beast. And what I mean by that is that during the time that we've been studying this disease, we've determined that there are certain characteristics that are very different between the two. So if you think of it along a spectrum, both neuroendocrine tumor and neuroendocrine cancer developed from a neuroendocrine healthy cell that went awry and started growing more than it should and learned how to spread where we don't want it to be. But their abilities to do that were different. And so if you're comparing a neuroendocrine tumor to a neuroendocrine carcinoma, histologically, meaning when we look at it under the microscope, The appearance is different. So that's something that you will see and that your clinician can discuss with you. Clinical symptoms associated can be different, meaning carcinoid tumors can be associated with carcinoid syndrome, which I'll talk a little bit later about, whereas poorly differentiated neuroendocrine carcinomas are not typically associated with carcinoid syndrome. The proliferation rate or growth rate, or that term Ki67 or Ki67, that is also very different between the neuroendocrine tumor versus neuroendocrine cancer. And then, as you can imagine, something that is growing faster has the ability to be more efficient at growing and spreading. And so the effect and burden on the body can be more notable. And that can affect the prognosis, where you have a disease that's growing faster and overwhelming the system versus a tumor that is growing more slowly and the body has more time to compensate for it. The prognosis is very different. So I'm going to start with the histology. And histology is our medical term for what does the tumor look like underneath the microscope. So you can see here the healthy neuroendocrine cell is on the left of the slide. So just a nice little oval cell with a nice circle within the cell is the nucleus. And I have taken from colleagues this graphic, which shows the differences when we look under the microscope to distinguish between something called diffuse idiopathic pulmonary neuroendocrine cell hyperplasia, or DIPNEC, meaning when we look under the microscope, there are still very similar features to the healthy neuroendocrine cell, but there's more of them than there should be. And that's where the hyperplasia comes from. So it's not quite in the cancer category, because although there's a collection of more cells than we want there to be, they don't look so haphazard. They look very similar to the healthy cell. The next column is the typical carcinoid. So this is where the tumor or the mass that we're seeing under the microscope is starting to look abnormal. So when we compare it to the healthy normal cell, we can see that there is changes here that it just doesn't look like how it's supposed to be. But because it's a neuroendocrine tumor or carcinoid tumor, the growth rate, or the number of cells that are actually actively growing and changing, is very low. And then you have on this spectrum, and I'll talk more about this difference in lung neuroendocrine tumors, but you have the atypical carcinoid, where you have more changes, more activity, and that's why we designate it as the same neuroendocrine tumor, but there's that different histologic appearance. And then on the other end of the spectrum, which again, that neuroendocrine cancer versus a neuroendocrine tumor, look at the last column where you have all these differences in the cells. And again, from a cartoon graphic, it really epitomizes that change, that difference where there's chaos and the cells are different sizes. The nuclei are active or inactive. Whereas when you compare it to the DIPNEC or the typical carcinoid, there's just a lot more structure, a lot more sense on the left side of this table versus the right side. And that's why the large cell neuroendocrine carcinoma is going to be more active, and the typical carcinoid or neuroendocrine tumor is going to be slower growing, because it still has a lot of features of the normal healthy, which is slowly growing, slowly evolving. And this is to address the second point, which was that proliferation rate or growth rate. And that's, again, another difference between neuroendocrine tumor and neuroendocrine cancer, is that you have this more rapid growth or proliferation rate, and really best epitomized by the cartoon graphic on the previous slide. But here I share the terminology for that we apply to non-lung neuroendocrine tumors, which are the well-differentiated grade 1, grade 2, grade 3, and then the poorly differentiated neuroendocrine carcinomas. So similar to the last slide, where that was really applying to lung neuroendocrine tumors, this nomenclature really applies to any what we call extrapulmonary or non-lung primary neuroendocrine tumors, going from neuroendocrine tumor. And the higher the proliferation rate, the more activity that we see, we characterize it as a poorly differentiated neuroendocrine carcinoma. What's important to distinguish here, and many patients will ask me, is at the time of their diagnosis, the pathologist, when they look at the biopsy, can apply one of these labels to what they're seeing underneath the microscope. This does not typically change over time. So if someone's been diagnosed with a well-differentiated grade 1 neuroendocrine tumor, over time, it is not typical for it to evolve into a poorly differentiated neuroendocrine carcinoma. What it can do is it can, over time, start to learn how to do more. And so its character may change. But if we were to biopsy it again, it is not common for us to see it change from a neuroendocrine, well differentiated grade 1 and then biopsy it 2 to 3 years into someone's diagnosis because disease is evolving and we see that it's become poorly differentiated. But this is commonly something that comes up during one's journey with their disease because they'll say, well, for many years, my disease was really quiet. We were watching it. I understood that. That made sense to me. And over time, it was comfortable. And then all of a sudden, my doctor is telling me that my scans are showing growth and it's faster than they anticipated. What does that mean? They're asking me if I want to have a biopsy to characterize it. Should I do that? And I think that's very much a personal conversation between the patient and the clinician because there's always going to be details that are important to drive that decision. But I would say on the most part, we're not looking to do that biopsy because we necessarily think we're going to see that change. It's just we want to gather more information. And we are hopeful that in potentially doing that repeat biopsy, because we're seeing kind of a change in the growth rate over time, that it may impact treatment options. And so, again, this is just to share with you, when you are diagnosed, you're typically going to fall into one of these characterizations of your disease, and it's not typically going to change. And so I probably took us on a long course to get us to this very, well designed table at which the WHO, which is the World Health Organization, created in order to have one language, so to speak, in describing neuroendocrine tumors, so that regardless of the language that we're speaking, I could say to someone who speaks German or who speaks Chinese that I have a patient with a well-differentiated neuroendocrine tumor and their grade is 1, and that's based on the Ki-67 proliferation index or the mitotic count. And this is all information that is going to be available on a pathology report. And a lot of work has been done to make this the standard. So when I've done retrospective analyses of patients who had pathology or biopsies done, let's say 15 years ago, it wasn't the standard practice. And you can see here, the WHO established this in 2019. There were previous iterations of it, but it wasn't standard practice to have this. So if you were diagnosed with your neuroendocrine tumor, let's say in 2012, there could have been a good decade or so where this Ki-67 or mitotic count wasn't something that you associated with your disease or that your provider spoke with you about, and that you were just told you had a carcinoid tumor or well-differentiated tumor or a poorly differentiated carcinoma. And it's really been more so in the last, decade that fortunately we've been able to, as a group of clinicians throughout the world, say, we want to be able to speak the same language. And this is how we now can say patients can kind of own their diagnosis and say, okay, I'm looking at my pathology report with my doctor or a clinician, and they're telling me that I have a poorly differentiated neuroendocrine carcinoma. And the reason is that on the pathology report, the proliferation rate is high and the appearance, like we talked about, that histology supports that neuroendocrine carcinoma versus neuroendocrine tumor. And this is just to share the WHO's classification system for lung neuroendocrine tumor, because as I described the histology slides for lung neuroendocrine tumors, you can see that there were different terms. Just as I mentioned with the non-lung neuroendocrine tumors, there were different terms, that grade 1, 2, and 3. Whereas with lung, we have typical carcinoid, atypical carcinoid, and then neuroendocrine carcinoma, either large cell or small cell. And again, I have many patients who come and say, you just told us that carcinoid isn't a great description of our disease. It's neuroendocrine tumor. Why is the WHO still using this term typical carcinoid or atypical carcinoid? Again, we're just all looking for a common language so that our patients can all feel that their disease is going to be managed and addressed the same as they would if they're seeking care in Mississippi or seeking care in London. They're going to have this classification system that is going to kind of be independent of language. So I just shared here the lung neuroendocrine classifications as a source of information. So, to address the last part of the initial slide of NETs versus NEC, we're going to talk about prognosis. And prognosis is based on the ability of the cancer to grow and spread and that effect on the body and the burden, right? And so, what many people have done over the many decades that we've known about this disease is try to equip patients and clinicians as to how do we guide you? How do we prepare you for what the journey is going to look like? And what has been proven time and time again is that if there's more activity and less differentiation, so the well versus the poorly tend to be more active. The low grade versus the high grade tend to be more active. That suggests that they're more efficient growers and they have a greater ability to spread and to burden the body. Whereas it's not that the low grade or the well differentiated don't have that ability, it just can take a longer period of time. And so you can see here on the graph where you have the yellow indicating the high grade and the green indicating the intermediate grade or grade 2, and then the black line indicating the low grade. There's a difference in months of overall survival for those patient groups based on the fact that you have faster growing tumors in the yellow line group, and you have intermediate, kind of some are slow, some are fast in the green group, and then you have the black line group that have the slower tumors. So people with those types of tumors are living longer with their disease. And then finally, it's the molecular characteristics. This is kind of where the wave that we've been riding as oncologists for the last decade is how do we get to know more than what we're seeing under the microscope? So I want to be able to tell you more about what your tumor can do, or I want to be able to give you more information about your disease than we can gain from just looking at the imaging or looking at the slides under the microscope. Unfortunately, technology has been moving forward and allowing us to assess the molecular characteristics, which in this case, or for this slide, is the DNA of the tumor cells. And what that means, and can feel very confusing, is that we are all born with DNA or a sequence of proteins that are the instruction manual for the body. And so, again, if you go back to those first slides about talking about neuroendocrine healthy cells transforming to neuroendocrine tumor cells, all tumor cells at one point originated from a healthy cell. So that healthy cell had the same DNA sequence as the rest of the healthy body. And that's what drove the healthy development of the body. But you can imagine if the instruction manual develops errors along the way, that's what we have come to know as part of the transformation process from a healthy cell to a cancer cell. And so we fortunately have been able to identify some of the errors that develop, that result, or at least contribute to the development of cancer. I'll highlight that we haven't identified all the reasons, but we have identified some genes, and that's what this slide is all about. So this slide is just to show that there's been a lot of work looking at the different genes, parts of the DNA sequence that when mutated, meaning the sequence has an error in it, that's going to contribute to abnormal growth or abnormal cell function, or the ability for a tumor cell to learn how to spread from where it's started from. And so we use this information to guide us. And in particular, in the table that I've included here, is sometimes when we look at tumors under the microscope, they may fall into this, especially for the non-pulmonary neuroendocrine tumors, it may be described as a grade 3 with a high Ki-67, and it looks similar to a poorly differentiated neuroendocrine carcinoma, but we know looking at it, it's not. And in order to better classify that, we've been able to determine, at least for pancreatic neuroendocrine tumors, that there's certain genes that are unique to neuroendocrine carcinomas of the pancreas versus neuroendocrine tumors of the pancreas. So you have here MEN1, ATRX, DAX, SETTD. Those are genes that typically, if they're mutated, they contributed to a pancreas neuroendocrine tumor developing. Whereas if we see mutations in TP53, KRAS, MYC, APC, RB1, those are genes that are typically mutated or affected and result in transformation to a neuroendocrine carcinoma. So now I'm going to shift gears a little bit and talk about the functional or the symptoms that can be associated with neuroendocrine tumors. And as I mentioned, is a kind of the final difference between neuroendocrine tumors and neuroendocrine cancers. So the big question is, do I have a carcinoid tumor? Do I have carcinoid syndrome? What does that mean? And really, carcinoid syndrome is a presentation where a patient may have symptoms that are associated with flushing or uncontrollable diarrhea or diarrhea that doesn't seem to respond to changes in diet or to medication, bronchospasm, which just means wheezing or almost like an asthmatic, someone who's with exercise will have some difficulty with breathing and needs to rest to kind of settle things down, or they may even have cramping or abdominal pain. And the prevalence, so if someone has a well differentiated neuroendocrine tumor, not all patients will have carcinoid syndrome. And what we've determined by studying populations of patients with well differentiated neuroendocrine tumors is that only about 20 to 35% of patients are going to present with carcinoid syndrome. And that's telling, and the reason why we as clinician scientists in the field have really tried to walk away from the terms carcinoid tumor and instead use the term neuroendocrine tumor, because it really wasn't describing everyone equally. And the trigger for carcinoid syndrome, again, is that signaling that the normal cell was doing, that when it became a tumor cell, started releasing that signal more erratically and not in response to the brain's assessment of the environment. And the trigger, the signals, the most common is serotonin. And when it's elevated, the healthy cells that typically respond to elevations or changes in levels of serotonin are going to respond because they're not going to know where the excess or the signal is coming from. They're just going to respond because it's kind of an easy equation. 1 + 1 = 2 type of situation where because there's a signal, the button's being pressed, so it's going to react. It's not that smart. So that's where these symptoms come from. And this is a cartoon graphic just to describe what I just mentioned. So you have the neuroendocrine tumor cell. It's releasing, as I mentioned, the most common is serotonin, but there are also other proteins that can be released from the neuroendocrine cells that then go to the target organs and cause more activity than they need to. And it's not in response to the brain's signaling. And so patients can present with, as I mentioned, flushing or coughing or wheezing. They can have abdominal pain, cramping, diarrhea. And there's also something called carcinoid heart syndrome, where because of the excess serotonin, damage to the heart valves can develop. And that's indirectly what can cause other symptoms like extra fluid in the legs or in the lungs. And so that essentially is carcinoid syndrome, is the neuroendocrine healthy cells normal function, just like the neuroendocrine tumor cell starts to grow more than we need it to, the neuroendocrine tumor cell starts to release some of the hormone more than it should. And again, it's not in every patient with neuroendocrine tumor, it's only in about a third. This slide is to describe one of the more common presentations of carcinoid syndrome, which is carcinoid diarrhea. And this can be very confusing. As I mentioned a few slides ago, the most common place for neuroendocrine tumors to develop is in the small intestine. And many patients will have some changes in their bowel activity after they have surgery to remove their tumor in their small intestine. And that can kind of confuse why they're having symptoms that they're having. But how we try to distinguish between, is there another reason for the diarrhea the patient's reporting, or is it the carcinoid, is that there's specific characteristics to carcinoid diarrhea. Meaning when I sit with a patient, I'm going to ask them, especially a new patient, I'm going to ask some of these questions. Is it happening despite not eating? So many patients will say for years, they've been having issues with diarrhea and they were changing their diet, cutting out gluten, they were cutting out dairy, and they were still having issues with multiple bowel movements a day. And they had colonoscopies and nothing was found. And that starts to raise suspicion that maybe this is related to it. And I have some patients whose primary care doctors or gastroenterologists astutely said, yeah, this is starting to sound more and more like carcinoid and not like an infection and not like a food allergy or food intolerance. And so the diagnosis kind of stems from there. What becomes confusing is that the other reasons for diarrhea can also have things like urgency or abdominal discomfort with it. But that's why we ask all the questions. And you can see at the bottom of all the writing underneath the table is that you can have other reasons like bile acid diarrhea, which can result in urgency. And many patients can develop this as a result of having their gallbladder removed during their either for other reasons or during their oncologic surgery to remove their primary tumor. Or they can have steatorrhea, and there are now many commercials about pancreatic insufficiency. And that's this type of diarrhea where your pancreas just isn't producing the proteins to help you digest your food. So the stool is going through more quickly, and patients will describe seeing floating stool in the toilet bowl or greasy appearing formed stool, and they're going frequently, but it's still formed. And so we know that that's different from carcinoid related diarrhea. Or short gut. As I mentioned, 55% of patients with well differentiated neuroendocrine tumors have their tumor in the small intestine. And to remove their primary, they had a surgery. And when they were brought back together, depending on how much of the small bowel was removed, the loss of those many feet of intestine may result in matter or stool or food going through more quickly because there's less to travel. And so that can be in the differential diagnosis. So this is going to be the reason why your clinician is going to ask you many different questions to describe your bowel function, is just trying to differentiate between carcinoid diarrhea and all the other reasons that may occur as the result of other treatments. Flushing is another common description. I think this becomes very tricky. And I have many new patients who'll say, after I was told I had a diagnosis of neuroendocrine tumor, I started to think, goodness, I think people have told me I get red all the time. Or women between the ages of 40 to 60 who are telling me about they just thought their flushing was, menopause or perimenopause. And the question really becomes, well, how do you distinguish something that can result from so many different reasons? There's not really a concrete way to do it. And it's really just trying to listen to what the patients are saying and trying to figure out what the triggers are. And with flushing, especially related to neuroendocrine or serotonin excess, there is no trigger. Or the trigger is that they've had a glass of wine and that results in flushing, meaning this feeling, which patients have described to me, where it's a burning hot sensation starting from their chest area and going up into their face. And if they could describe it as a computer graphic, it's like someone's lighting a lighter, just below their chin, and they're feeling like their face is on fire. And someone sitting across from them will say that their face looks beet red. Obviously, not everyone's flushing experience is the same, and there can be variations of it, but that's typically what I'm looking for in the description of with that experience. And what has been commonly shared with me is that it's not something like a hot flash where there's sweating involved. It really is just this really warm sensation that's just in the chest area up into the face. And it can be intermittent. As I mentioned, it can be food triggered, but most of the time it's just someone is sitting and relaxing, reading their book, and their companion just looks at them and says, wow, do you need me to open the window? You just look like you just are getting really uncomfortable, that type of thing. So now I'm going to move on. We talked about the differences between neuroendocrine tumor and neuroendocrine cancer. And now we're going to talk about what's the best imaging. Why do I keep hearing about the different types of scans that can be done for what type versus the other? This is the alphabet soup slide, which is going to describe all the different imaging modalities that are available to assess a patient's disease burden. And again, remember, none of these imaging modalities can diagnose the disease, but it can provide us an overview of where the disease burden may be. And we use all of these, or some of these, or one of these and it really depends on the patient and depends on what we're able to gain and what appears to be limited in information from one scan to the next. And so, what many people will hear about are PET scans. And PET scans are commonly associated with cancer assessment. The FDG PET, which is the third bullet on this slide, is one that's used for all cancers. And the reason for that is that it is the contrast agent that they give patients when you go in for the scan has a little protein in it that is attracted to actively growing cells. And if you think of it like a little tadpole, the head of the tadpole has the protein that's attracted to the actively growing cells, and the tail is like a sparkler on a July 4th holiday, where once it attaches to the tumor cell, if there's enough cells all together, when you go through the machine, it takes one image that's like a CAT scan. And then when you come out and you go back in again, that's when the image is taken where the sparkler, so to speak, is present. And if there's enough of them, we're going to see that on the FDG PET scan. What's different between the gallium dotatate and the FDG PET scan is the gallium dotatate is specific for neuroendocrine tumors. So there's a specific protein that's only found on neuroendocrine tumor cells. And so same concept with the tadpole and the protein. So the head of the protein's only attracted to this protein on the neuroendocrine tumor cells. And again, the sparkler on the tail is going to light up only if there's a critical mass of tumor cells altogether. And so we use one versus the other really based on the diagnosis and what we're looking for. And there are other scans here, the SPECT scan or the MIBG scan, which are used in certain circumstances, but not as commonly for diagnostic reasons like the FDG PET or the gallium dotatate PET. And then the CAT scan or CT, MRI or endoscopy are all general imaging modalities that many patients will have undergone as part of their diagnostic workup. And if it provides the detail we need to know the burden of disease, we will continue to use the CAT scan, the MRI, or even endoscopy to follow the progress of someone's cancer. And so this is, again, I like to repeat myself, and I think images help with this. It's right tracer, right tumor. So as I mentioned, the FDG PET is one that is attracted to actively growing cells, and that's why we use it for, the more typical cancers. And the more typical cancers are more similar to the poorly differentiated neuroendocrine carcinomas, whereas, as I mentioned, the well-differentiated are slower growing. So that FDG PET won't have a lot to stick to because there's not going to be a lot of actively growing cells at any one point in time. And so we are able to use the gallium PET dotatate to look at the well-differentiated because that SSTR or somatostatin receptor is the protein that, again, as I mentioned, the head of the tadpole is attracted to that somatostatin receptor that's unique to the neuroendocrine cells. And because on the tumor cells, there's so many of these receptors, when we take the image and there's a critical mass of tumor cells, it's going to light up. And so that's the difference. So between NET and NEC is really, if you have a NET tumor, we're going to be talking about doing a gallium dotatate. And if there's not uptake, that means that there's not enough of these somatostatin receptors on the tumor cells. And that's when your provider may suggest that you have an FDG PET. And if you have a poorly differentiated neuroendocrine carcinoma, your provider will likely discuss getting an FDG PET, and it will be the reason why they don't feel a gallium dotatate is of benefit because there's a very low likelihood that you're going to have somatostatin receptor proteins on your poorly differentiated neuroendocrine carcinoma cell. And you can see here if, I did not train as a nuclear medicine radiologist, but these are the images that we gain, and they're very similar. But this is the same patient getting an FDG PET scan and a dotatate PET scan. On the left side of the slide is just the overall view of this patient. And on the right side is just one slice through the same part of their body, which is the lower abdomen around where the pelvis is starting. And the reason I'm showing you this is that for the same patient, you can see that there's some areas that are represented here in black as being areas that there's disease. So on the FDG, that's showing the active cell growth. And on the dotatate, you can see that some of those areas, if you're looking at the left side of the silhouette, we don't have it all matching up. And so this suggests that there's areas that, although we know disease is there from the FDG PET, those same areas don't have the somatostatin receptor. And so on the PET dotatate, don't what we call light up. And so that's the image on the right side. Is you can see the yellow areas is quote unquote where the contrast is concentrating and quote unquote lighting up, because there's disease there. But when you look at the PET dotatate, which is the image below, those same areas are areas of disease, but they're not lighting up because they don't have the somatostatin receptor, or at least enough of them on the tumor cells so that the contrast agent would concentrate there and light up on the scan. Now I'm going to move into, as I mentioned, and attempt to answer the question, why are some therapies available to me and why are some therapies not being offered to me? And it really depends on the diagnosis, as I mentioned. And here I'm just including small intestinal neuroendocrine tumors or carcinoid tumors and pancreatic neuroendocrine tumors, and then neuroendocrine carcinomas to make a comparison. And so you can see here, and I apologize, I've left out lung neuroendocrine tumors, but they are very similar, will fall into a very similar profile as the small intestinal neuroendocrine tumors here on the slide. And you can see that there's a lot of similarities between the small intestinal or carcinoid tumors and the pancreatic neuroendocrine tumor treatment options, but those same options are not options for neuroendocrine carcinomas. And vice versa, you can see in the neuroendocrine carcinoma column, there are multiple chemotherapy combinations that are considered standard or FDA approved, but they are not falling into the same category for pancreatic neuroendocrine tumor or small intestinal neuroendocrine tumor. And most importantly is the last row, which is the lutetium dotatate, also known as PRRT or Lutathera, is only FDA approved for small intestinal neuroendocrine tumors or pancreatic neuroendocrine tumors. But as I just showed you on the previous slide, if the somatostatin receptor isn't there, or the PET dotatate doesn't show that the tumor didn't on for that patient's image, and that suggests a neuroendocrine carcinoma, the lutetium or the PRRT isn't going to be an option. And so, in summary, important features to know of your disease that help us determine what your treatment options are going to be. And this is a nice little table that you and your provider can kind of put together for you. I attempt with my patients to put it in my clinical notes. So if you have, access to Patient Gateway and you can see the notes that your provider writes about your visits, you should be able to get these kind of characteristics that your provider is using to help guide your treatment journey. So first is that histology. Is it well differentiated or is it poorly differentiated? Primary site. Is it small intestine, lung, pancreas, somewhere else? Grade, again, that K67 or mitotic index, and the WHO, the World Health Organization's breakdown, that common language that we can all describe our diseases with, whether we speak one language or another. For lung, we have typical, atypical, or small and large cell carcinoma, where the extrapulmonary are non-lung, like small intestine or pancreas, it's going to be grade 1, 2, and 3. Again, based on that mitotic index, based on that K67. And then the next row is functional or carcinoid syndrome. Do you have that? Is that something that's been discussed? Imaging. Has your disease been well characterized on a gallium PET dotatate scan, or is it better characterized on a FDG PET scan, or neither, right? That's important to know. And then stage. So stage is a term that describes any cancer. So it's not unique to neuroendocrine tumors or neuroendocrine carcinomas. And that's really just where in the body is the burden of disease. So 1, 2, and 3, typically limited to where the disease started. So if it started in the small bowel, then 1, 2, and 3 is typically how we designate that. And the differences are really based on the size and whether lymph nodes are involved. Whereas 4, common to other cancers, means that it has moved away from where it started from and moved away from the regional lymph nodes and has spread. And so that's what stage 4. So knowing those different characteristics can really be the platform for discussion about treatment options. And I'll go into this because I think this is one of a really common question that comes up for new patients is who gets octreotide or lanreotide? So again, if I have that card that I've made of my diagnosis, we're really looking for patients that are going to be candidates are going to have well-differentiated tumors. Their grade 1, 2, or 3 is kind of independent. It's really the well-differentiated or not. They're not going to be the patients with the neuroendocrine carcinomas. And typically it's because the somatostatin receptors aren't present in the neuroendocrine carcinomas. And it's really more that they're more highly present in the neuroendocrine tumors, and why we use the gallium PET dotatate to identify if they're present and why the octreotide or lanreotide is an option. The other circumstance that's unique to neuroendocrine tumors and unique to the decision making in regards to the use of octreotide or lanreotide is that functional or carcinoid syndrome presentation. So if patients have been diagnosed with carcinoid syndrome or functional tumors, then octreotide and lanreotide are going to be part of the first line of therapy because we know that they can help subdue the symptoms that are resulting from the carcinoid syndrome. And those are the two circumstances where we'll consider octreotide or lanreotide. Again, just a summary, it is for the patients who have functional symptoms or carcinoid syndrome, but also for the patients who have PET dotatate scans that confirm that there's somatostatin receptors on their tumor cells. And those typically are the well-differentiated. Another common question in regards to treatment is, why did my doctor tell me I'm not a candidate for PRRT? And again, kind of probably I doing a disservice because I'm using the term PRRT and I should be using all the other terms that have been commonly used for it as well, which is Lutathera or lutetium dotatate. It's a treatment. PRRT is an acronym for peptide radionuclide receptor therapy. And it is a combination of, we use peptide, which means a protein that's attached to a radioactive material. And so it is only used if there is the receptor, which in this image is the little black arrows that are on the blue circles. The blue circles are the tumor cells. So if the tumor cell has the somatostatin receptors, then PRRT or lutetium dotatate can be used. What is unique to this lutetium or PRRT is that we use the same protein or the same kind of tadpole with the head and the tail to use it for imaging. So that PET dotatate is using the same technology. It's just at a much lower dose than the PRRT is using the same technology, but as a treatment. So that's the difference between PET dotatates and Lutathera, which is the treatment type. I include this slide to show you the benefits of PRT or Lutathera. So on the left side of the slide, you can see the silhouette again. It's an image taken from the PET scan where the black areas in the silhouette represent disease. And it represents, more importantly, disease that has somatostatin receptors that would be where the PRT or the radioactive material is going to be attracted to. And the images just to the right of it are just representative slices of that silhouette. The top image showing the CAT scan image, which shows kind of some of the darker areas representing tumor. And on the bottom is the dotatate image, meaning where it's quote unquote lighting up. And so it's just to represent those areas. And you can see here the really impressive results after Lutathera or PRRT, where some of the areas are no longer black, are no longer avid or lighting up on the PET scan. But you can see on the upper image, which is the CAT scan, that there's still tumor there. So it's not a cure, but it's a really effective treatment. And so very encouraging. And has proven to be a really great therapeutic option for some patients. The next question that is commonly posed to me is, I have a neuroendocrine cancer, and I just heard or saw on the news that the FDA approved a drug called cabozantinib. Is it an option for me? And unfortunately, it's not. It all stems from how we design trials. So the cabinet trial was designed by my colleague, Dr. Jennifer Chan, who recently published the results. And when we design trials, we have to make sure that we're asking specific questions. And what that will mean for the neuroendocrine community is that we're going to identify disease groups that once we finish the trial, we'll be able to confidently say if the drug was effective, that it was effective for that group. And it becomes too complicated, and we can't offer it to everyone when we make it more of a mix of patients. So we already know neuroendocrine tumors act differently than neuroendocrine carcinomas. And if you remember that table in which the treatment options are very different between the neuroendocrine tumors and neuroendocrine carcinomas. So when Dr. Chan designed this trial, knowing that non-pancreatic neuroendocrine tumors, the treatment options are very similar to pancreatic neuroendocrine tumors, that was why this trial was really looking to see if cabozantinib could be added to that table. And fortunately, the results show that it is a good option for patients with extrapancreatic, meaning not starting in the pancreas, or pancreatic neuroendocrine tumors. But patients with neuroendocrine carcinomas were not included in the trial. But in this trial, patients were randomized to receiving cabozantinib 60 milligrams a day or placebo. And what was published was that the overall survival was improved in the patients who received cabozantinib, whether or not their primary was in the pancreas or outside of the pancreas. So you can see here for those patients with tumors that started outside of the pancreas, the overall survival for the patients that received cabozantinib was longer, so 21.9 months, whereas those that received placebo was 19.7 months. Whereas for the pancreatic neuroendocrine tumor cohort, you can see the median overall survival for the patients with cabozantinib was up to 40 months, and for those that received the placebo was 31 months. So that difference was part of the argument presented to the FDA to have this drug approved, and they did approve it. The next question that is commonly presented to me is, can I have immunotherapy? Why isn't that being offered? I'm seeing it when I'm driving to work. I'm seeing it on the billboards. I've talked to, Aunt Lucy, and Aunt Lucy said that her neighbor received it. Why isn't my doctor offering it to me? And there's good reason why it's not being offered, because I promise we have been investigating diligently whether or not the same immunotherapy drugs that seem to be effective in other cancers, we've been trying to figure out if they're effective in neuroendocrine tumors. And over the last decade, a lot of effort has gone into this. And unfortunately, we're just not seeing the same results as we're seeing in other cancers. So I have here one table on the left side that just describes the response rates and the progression-free survival, or time to progression, that was reported for the various trials of the FDA-approved treatments in well-differentiated neuroendocrine tumors. And you can see here, it's a slow-growing tumor, and so the response rates can be as low as 2%, but with chemotherapy in the last one, as high as 33%. And the progression-free survival, or time to progression, can vary between 11 months and be as high as 40 months, which is what we saw with PRRT. On the right side, the table includes 4 different types of immunotherapy drugs. And what we're seeing is, although the response rates may be similar, so we have as low as 3%, just as we've seen with octreotide, or 20% like we saw with PRRT, the problem is that maybe there was evidence of response, but the response did not last long at all. So you can see here that the time to progression was as short as 2 months, and as long as 4 months. And so that limited benefit, even if 3% of patients responded by the measurements that we follow in clinical trials, like we saw for octreotide, the fact that that response only lasted for a couple of months means it's not a good option. So, what we soon looked at, and there was a very large trial looking at a group of patients that had what we called rare tumors, and neuroendocrine tumors are rare. And fortunately, this trial included a good number of patients who had neuroendocrine tumors. And what they determined is if you combined two different immunotherapies, that maybe you could get a better response than if you gave just one immunotherapy. And so this was a reassuring trial because we had a good mix of the different neuroendocrine tumors. We had the typical and atypical lung, we had the grade 1, grade 2 GI and pancreatic neuroendocrine tumors, and we even had the grade 3 neuroendocrine tumors included. And what you can see here is that the overall response was highest in the tumors that had a higher grade. So in the bottom right corner, these images or these graphs, anytime the bar is going in the upwards direction, that means that we were seeing growth, and in the bottom is showing partial response. So it's not as intuitive as you would think. So you'd think if it was in the positive direction, that means that that was a response, but it actually means that there was growth. So you can see that there weren't that many responses. So in the top two graphs, you can see that there's just a handful, about 6 or 7 patients in the GI neuroendocrine tumors or in the lung neuroendocrine tumors that responded, but the response was not that long. Whereas in the grade 3, in the graph E on the bottom right, you can see that there was response, and the response seemed to be a little bit more durable. And so what we've taken from this is that there are going to be certain circumstances where if we see the Ki-67 is high, meaning it's greater than 20%, meeting criteria for grade 3, and a patient has received the other standard options, the discussion about using a combination of two immunotherapy drugs to treat the disease may be considered. But for patients who have well differentiated or typical or atypical lung neuroendocrine tumors, the benefit just hasn't proven to be there. This is another common question, which I mentioned in our initial outline of what I wanted to touch on during this discussion, which is, should I have blood work to follow my disease? And this has been something that has evolved over the last decade as we've been able to conduct more trials, what we call prospective trials, following patients. And as I mentioned, neuroendocrine tumors can release chromogranin or serotonin. And the release of the serotonin is the signal, so to speak, that it passes. And unfortunately, as we know, not all patients who have neuroendocrine tumors will release excess serotonin. And I mentioned earlier, it's around a third of patients that may have that. And so that's where this blood testing becomes limited. So chromogranin or 5-HIAA are basically the body's breakdown of serotonin. And if not all patients with neuroendocrine tumors are releasing it, that already is the first kind of crossroads where the benefits become limited, because if only a third are, you can check it, but it's not a guarantee that it's going to give you a good sense of what the disease is doing. Second is that although even in patients who have carcinoid tumors or functional tumors, these levels you would think would represent the activity of the disease, the problem with them is that your body is making serotonin to function normally, and there are other triggers that the body needs to respond to. So there can be fluctuations from morning to night in those levels, and depending on when the blood work is drawn, you may have results that are representing just the body's normal response to a normal stress, and not an accurate reflection of what the tumor itself is releasing. And so in this table, rows 2 and 3 are the sensitivity and specificity. And those are statistical terms that really describe if something is positive, then the higher that percentage is, means it's going to be pretty reliable that it indicates that there's disease. And the sensitivity, if it's negative, it means if it's a low percentage, that means that, well, if it's negative, you just don't know if it's truly negative. And that's a problem. And that's the limitation. And the last two columns in this table really are intended to address what are the advantages. So we never want to disregard something, but we also want to know why clinicians may not be offering it, or why is the practice so mixed. And I think that there are clinicians out there that kind of approach this and say, well, I just want to know as much as I can. And even though that this lab isn't proving to be as reliable, maybe if it's reliable for one patient, then I'm just going to keep doing it. And that's not an unreasonable approach, but for patients, it's important to understand that if your doctor isn't encouraging or isn't ordering this, it's not to frustrate you or to limit the assessment of your disease. It's fraught with so many limitations that we want to empower patients to know what's going on with their disease and not have them ride a roller coaster of a blood test that can be very fickle and go up and down, and it can result in a lot of emotional toxicity. And so for gromagranate, I would say that's really where I have found that it's limited and causes more distress than help. I believe this is my last question that I posed. And again, this is an important question that we all ask as members of families: did I develop or inherit the risk of developing my cancer? And this is a field that is still growing. And so I think that with what we know at this time, it is more unlikely that the disease or the neuroendocrine tumor, the risk was inherited. But important questions to ask that may take you down the road with your clinician about whether or not testing should be considered to assess your risk is: are there other family members with a neuroendocrine diagnosis? And are they first degree relatives, meaning is it a sibling? Is it a parent? Is it a child? It becomes a little less relevant when it's, your second cousin once removed, because as you can imagine, the shared blood, shared DNA is definitely watered down when the relation is that far apart. But, if it's multiple siblings have that neuroendocrine diagnosis, I think it should be investigated. There is a very common inherited syndrome called MEN, which is multiple endocrine disease inherited syndrome. So if there are family members with various endocrine related diseases and there's neuroendocrine tumors, that would be a good reason to consider testing. If a patient has more than one primary neuroendocrine tumor, meaning a primary site in the small intestine and another site in the small intestine that's not thought to be metastatic, they should be considered for testing. And then non-neuroendocrine related indications is the patient have more than one cancer diagnosis in their lifetime. So that's an important reason. And one type of neuroendocrine tumor that currently is associated with a 30% in inherited risk are the patients who have paragangliomas or pheochromocytomas. And at this time, because upwards of 30% of patients have their diseases associated with an inherited risk, we're recommending that all patients with that diagnosis get tested. So I shared a lot of information, and I'm hoping that it at least jogged your thoughts and memories of what you need to talk with your provider about and what information you need to know so that you can be an active member in your journey, in your therapeutic journey, and what we as your doctor team are using to help guide us in regard to your therapeutic options. So just remember, every journey is unique, and share questions with your provider to make this journey more doable. Thank you.